case will be performed by Dr. Hussein Ukasha from Cairo. Welcome to this meeting. And you've got a very interesting case that you want to share with us. Can you tell us more about that?
Yes, here, as you see, the medical history of the patient. The patient has recurrent episodes of hypoglycemia. Glucose decreases as low as 40 milligram per 100 cc. At that time, the fasting insulin was very high. It is about 66 micro international unit per milliliter. And the fasting C-peptide is 6, which is high, especially in the setting of hypoglycemia. It must be 0. CT revealed well-defined homogeneous mass, about 10 by 16 millimeter in the pancreatic body, and EUS was done showing this very clear mass. And for more confirmation, FNB was done and revealed insulinoma, and the Chi index is Chi 67 index is 100%. The issue was discussed by the patient, and the patient refused to do major surgery, and he preferred to do EUS-guided radiofrequency ablation. As we all know that the guidelines till now is surgery, then surgery, then surgery. But in the last few years, the emerging of radiofrequency ablation guided by endoscopic ultrasound offers another option to the patients, and now left for the willing of the patient. Is he prefer major surgery or radiofrequency ablation? And also, of course, in cases in patients with poor risk for anesthesia. So the patient preferred radiofrequency ablation and is now scheduled for EUS-guided RFA. Just a small hint about the machine. This is a machine which generates heat, the processor Viva Combo, and the cooling system. And of course, we will work with Fuji echo endoscope 580 series. Just a small hint about the cooling system. This cooling system has 2 limbs. One limb is the blue one. One limb is the blue one. The blue one brings cold saline to the needle. Yes, this is the blue limb, brings cold saline to the needle, and the cold saline will come back through this white limb. There is this white limb to the trash. The aim of cooling system is to keep the needle cool, about 0 to 5%. Why? Because keeping the needle cool despite surrounding heated tissue prevents stocking or adherence of the needle to the surrounding tissue, and also decreases the incidence of charring. Charring is raising the temperature more than 180 degrees. Charring and carbonization is not desired at all in radiofrequency ablation, because charring, charred tissue limits the spread of injury to the surrounding. Also makes tissue very friable, so increasing incidence of perforation. So the ideal temperature for ablation is between 60 degrees centigrade and 100 degrees centigrade. Below 60 is not lethal. It is sublethal dose. May increase inflammation, hyperemia, and this may help in sensitization and augmenting immunity. But the aim is to raise the temperature between 60 and 100 degrees centigrade, not less than 60 and not more than 100 to prevent charring. So this is, and of course, before the procedure, and this is the needle. Just a small hint about the needle. This is the needle. You see, more or less like the FNB needle. This is the distal calibration, which extrudes the sheath as a whole from the echo endoscope, exactly like FNB needle. And the upper calibration or upper graduation is about 8 centimeter in order to eject or extrude the needle from its sheaths, exactly like FNB needle. Of course, before starting the maneuver, the patient, we give the patient suppository leometacin, indomethacin, exactly like ERCP, to decrease the incidence of pancreatitis as it is recommended from the experience of the previous patients. And also now we will start the maneuver. First, I'd like
Can I ask you something?
Yes.
So, so there are 3 needles available, no? The 5, 10, 15 millimeter with the 15 millimeter. So, which one did you choose? Are you going to choose for these patients based on the lesion characteristics? And do you plan to perform a certain number of ablation in one session, or you just gonna go ablation until you think it's ablated? And are you going to do contrast enhanced EUS before to check after your treatment, or not?
Yes, regarding the first question, I will use 1 centimeter, as you see. This is the blue one is the insulator, and the needle is 1 centimeter. You see?
Yes, but because
Yes,
the lesion is 1 centimeter to 11 millimeter in length, but it's like 6 millimeter in maximum diameter. So, you know, in my opinion, a 5 millimeter would be more safe.
The lesion is 11 by 16 millimeter.
By 16, eh?
Yeah, 11 by
sorry. Sorry. I understood. 11 by 6. Sorry.
Now I am measuring in the screen. You see the screen.
Sorry.
Exactly 11 by 15 millimeters.
Okay,
so
sorry.
Again, so I choose 1 centimeter, and my policy is to do first ablation.
Okay.
I use 50 watt for about 10 seconds. But my policy is to observe the cloudness. When the lesion is completely filled by hyperechoic cloud or hyperechoic veiling, then it is enough. But in most cases, as I did about 12 cases, about 10 seconds is enough in most cases with 50 watt.
So you stop when you see the bubbles, the white bubbles.
Yes.
So you don't stop with the impedance.
Yes. Both are synchronizing with each other. Impedance becomes very high, and then by then the veiling is completing or opacifying the whole lesion. Usually both go with each other.
And are you giving any prophylactic treatment?
Yes. I just said that we indomethacin and prophylactic antibiotics.
Perfect. So you are ready to go.
As you see, the first 3 cases of radiofrequency ablation, 1 case complicated by acute pancreatitis and another case complicated by infected pancreatic collection. So the recommendations by then emerged by advice to give non-steroidal anti-inflammatory like ERCP, exactly, indomethacin, and prophylactic antibiotics.
Perfect.
Okay, now we'll start the maneuver. This is a Fuji. The patient is intubated. Not all patients needed to be intubated, but this patient, I prefer to do intubation because to be free in time. But the usual practice is also deep sedation by propofol is also applied in some patients. Now I will search my landmark, which is the abdominal aorta. Very nice, and the left cross of the diaphragm is. We need
to see the EUS view bigger, please. It's only small. It's small. EUS perfect.
Yes. First, I'd like to welcome my dear colleague and thank him very much for his great effort, Dr. Muhammad Sharif Naguib. Dr. Muhammad Zidan is anesthesia, and Mr. Amir, the technician of echo endoscope.
Hussein, do you have experience only with functional net, or also with non-functional net?
Both. both. That out of the 12 cases, 10 were insulinoma. 10 were insulinoma, because I think it is the future and it will enter the guideline very soon.
Yes. Yes.
Why? Because insulinoma is mostly benign. Very, very rare to see metastasizing insulinoma.
Yes.
In contrast to other, you can't ablate 100% of the tumor, really. In practice, it is impossible. So we need some cells. But insulinoma,
surgeons sometimes they said that they quote very, very old literature about 10% rate of metastasis from insulinoma, but this is really rates in the literature from the 1980 when probably diseases were picked up later on in their course. So right now, I think it's very, very uncommon to see a metastatic insulinoma.
Yes,
also because usually insulinoma are diagnosed early because they are symptomatic. So when they are small.
Yes, exactly. And if you ablate about 90% of the tumor, then the patient will get rid of 90% of his complaint, and he can cope with the residual minor symptoms. So I think it is ideal, very ideal, especially for insulinoma. But gastrinoma is more aggressive. It metastasizes. Somatostatinoma is very aggressive, but insulinoma is usually a benign disease. So I think the most suitable lesion for radiofrequency ablation will be insulinoma exactly. Do you agree with me? Yes, you are hearing me? Now we are just below the cardia. I am about 43 centimeters from the dental arch, and here this is very nicely seen splenic artery and splenic vein. This is the splenic artery, yes, and this is the splenic vein. So this is the body of the pancreas. Here I will scan the body of the pancreas. This is the kidney. I will scan the body. Yes, here very nicely seen. It is a well-defined focal lesion in the pancreatic body. This is the pancreatic artery. Shower Ali. This is the pancreatic artery. This is the splenic artery. This is the splenic artery. And below is the venous confluence. Very nicely seen. This is the splenic vein. This is the splenic vein.
It was the
this is
lesion,
the splenic artery, and this is the splenic vein uniting with the superior mesenteric vein to form the portal vein. So this is
the lesion was detected on CT, but not on MRI, right? Correct?
Detected by CT.
Yeah, but not MRI.
Not MRI, by CT.
So what do you have any experience? There are some patients with the hypoglycemia and all the workup, but then nobody's able to find a lesion. MRI is negative, CT is negative. Do you have any experience with the EUS in this type of patients where all the other tests are negative, but there is a clinical syndrome suggestive of insulinoma?
Yes, a very nice question. Out of the 12 patients I did radiofrequency ablation, 10 of them, or I think 9 or 10 of them were negative in CT and in CT exactly. But MRI is more sensitive. 4 out of 12 was positive in MRI, while 8 patients were negative. 8 out of 12, a large number of patients, were negative for MRI and CT. Not only that, but even technetium gallium dotatate PET-CT. In our country, in my country, it is not so sensitive. Only 6 patients out of 12 patients, and 50% of patients were negative by gallium dotatate PET-CT. So I don't know why. Although in the literature are saying that gallium dotatate PET-CT is very sensitive, not the usual PET-CT, not the FDG, not the deoxyfluorinated glucose. The special one, special dye, which is dotatate PET gallium, is also not so sensitive in that. It is only in 50%. So I recommend strongly endoscopic ultrasound if CT, MRI, or gallium dotatate are negative. But there should be a proper clinical and lab setting.
Yes, because
Insulin
otherwise,
should be high.
otherwise it becomes very confusing, right? You have to have
yes, factitious.
Yeah, because then you start seeing insulinomas everywhere.
Yes, exactly. So there should be a proper clinical and lab setting. If the imaging is negative, then we should do endoscopic ultrasound, and in most cases we can find the insulinoma. Now, this is the mass, very nicely seen. Fix, freeze. Try to measure it. It is about 16 or 17 by 9 millimeter. It is 9 by 17. Okay. Now we will start ablation.
So one important point, I think, so this lesion is very close by to the gastric wall.
Yes.
So I think it's important when you finish doing the first ablation to leave the needle like few seconds inside the lesion to avoid to burn the gastric wall.
Yes, I will do that. And another thing, two things to be done before ablation. It is away from the pancreatic duct. If the pancreatic duct is nearby, then it will be a risk for pancreatitis. Now here there is no pancreatic duct, and of course applying Doppler, color flow Doppler to see if there is an intervening vessels at the track or at the pass of the. These vessels is inside the mass itself. It is not an intervening vessel. The splenic artery is away. Then I think it is time to start ablation. I will introduce the needle. Lock it. From the distal calibration, I will extrude the needle out. Yes. Yes, this is the needle here. I will fix the lower calibration. امسك بقى كده يا محمد. Yes. And here I will proceed the needle. Yes. Very nicely. Now I am inside the lesion, and I will push the needle to the distal part. Just as you mentioned, it is near to the gastric wall. So I should push the needle to the distal part of the lesion. Now it is, you see, very nicely seen. It is.
You use 50 watts.
50, yes. 50 for 10 seconds.
Okay.
Now starting water irrigation to cool the needle and then start ablation. Yeah. Start. Yes. 1 second, 2 seconds, 3 seconds. Yes. Now starting.
Okay, now you start seeing the effect, the bubbles.
Yes. 10 seconds. لا كمل. 10 seconds. There is feeling, but I need more. Yes, now more. Yes, very nice. Stop now. Stop. Okay. Stop. It is about 13 seconds or 14 seconds. I stay for a few seconds. خلاص, stopped. And then I will withdraw the needle.
So how many passes of RFA will do in this session? 3?
I will stay for a while and look for, if there is still hypoechoic area, I will do a second pass. I think here I'd like to do a second pass because still, yes, this ablated, this area is ablated, but this is still not ablated. So I will go this here.
Did you able to get it?
What? Yes.
Sorry, no.
Yes, this is the. I will ablate this remaining area, I usually do 2 to 3 passes. And this is the needle here. Yes, I am now exactly inside the hypoechoic area. I start a second ablation. Yes, start.
So in the study we have done, the RAPNet study that is on functional, non-functional net. We actually had a meeting in Rome before starting to optimize the treatment and to make it all the same. And we established not to do more than 3 ablation per session to decrease the risk of acute pancreatitis.
Yes. My mean number of passes is 2 passes in each patient.
Yeah.
Now, nicely, the remaining hypoechoic part are now very nicely. It is whitish, and see, this is the lesion. I think 2 passes is very nice. So up, unfortunately, there is no contrast, but we observe the clinical picture of the patients, the lab of insulin and C-peptide, and after 10 days, we repeat.
So what?
We repeat the contrast to the effectiveness of radiofrequency ablation.
I think at the beginning you were correctly stating that probably in more very close, this technique will become a standard of care for insulinomas and probably will become first line because you know the complication rate of surgery are very high for pancreatic surgery. And yes. You know, despite what the surgeon says that you know, US RFA has the same complication rate as surgery, this is not true. I think the patients, one patient that has insulinoma should see both the surgeon and the endoscopist, and then to be, after explanation of each of the technique, to be free of choosing what they think is the best for them. So if the patient is not able to not have the security 100% that the tumor is out, should undergo surgery. Otherwise, the way to go is for sure endoscopic ultrasound radiofrequency ablation. So it would be nice for surgeons to start sending always patients with insulinomas or other rare functioning net to centers where US RFA is performed. Don't you think so?
Yes, I think so. In the start, I am very, very encouraging and very, very supporting using radiofrequency ablation, especially in insulinomas.
Yes.
And multidisciplinary team in Cairo University, in Qasr Al-Ain Hospital, where I am professor there, a multidisciplinary team with the surgeons, those professors of surgeons, both are agreed with me that insulinoma is very candidate and very nice for radiofrequency ablation, because all surgery for insulinoma has complications, morbidity and mortality.
Yes.
If there is inoculation followed a high rate of sinus formation and leakage, and distal pancreatectomy is somewhat aggressive lesion, somewhat aggressive operation for the patients. So they agree with me for insulinoma, but I am not encouraged at all for adenocarcinoma, for down staging, or just for small lesions, like especially for insulinoma, maybe some cases of non-functioning net, small one, instead of doing.
So there is a recent paper from Stefano Crino, with whom we collaborate, and is a propensity score matched study comparing US RFA and surgery for the treatment, and
surgery.
clearly
Below that,
treatment success is similar. Surgery is 100%. US RFA is a little bit lower, but there is no differences. While there are differences in terms of adverse events that are clearly significantly higher in the surgical group. And Stefano is organizing, actually, as already the protocol that has been also published, a randomized control trial comparing US RFA versus surgery for these patients. And it's also important to take in mind that if US RFA fails, there is always surgery. So there's always another option, and it's kind of a step-up approach where the minimally invasive approach is used first, and in case of failure, then you have a backup that is represented by a surgery, who is actually much more invasive. So I think surgeons should start referring patients for this procedure, at least for a discussion, because at the end, who decide what treatment should be done is the patients and not the doctor. The lesion is not visible.
Yes, it's not. It is now hazy and big, and even we notice here that the vascularity, the color is around the lesion and not inside the lesion. At the start, the region was hypervascular, many color flow signal inside. Here we notice that the lesion becomes more hazy, not so clear, and there is no color flow signal at all. The color flow signal and the vascularity is around the lesion and disappeared from inside the lesion. And this peripheral vasculature is inflammatory response and may be beneficial for stimulating the immune system as written in the literature. Now I can go out and watch the patient follow up. Last point to mention, or last 2 points, as you said, surgery are now very cooperative in sending patients of insulinoma. I did 12 cases, 10 of them were insulinoma. No one in the 10 patients needed surgery, but one patient needed 3 sessions, not 3 passes, 3 sessions, only one patient, and 2 patients needed 2 sessions. And the other 7 patients, only 1 session is enough to cure the patient completely. The second point is, what about alcohol injection? Alcohol is much more cheaper, absolute alcohol, 95 to 100% alcohol. Of course, it is much cheaper, and we did with my colleagues in Egypt about 14 cases of EUS-guided alcohol injection. And as you said, 10 patients with insulin, 12 patients radiofrequency, 10 of them were insulinoma, and comparing 12 cases with
the alcohol injection, at least from the literature, there's a higher rate of complication, probably related to the difficulty in controlling the diffusion of the alcohol, not only the lesion, but surrounding the lesion. So I would not recommend alcohol now that we have radiofrequency ablation. So I think in our experience, we are sending for publication a paper with 30 patients prospectively enrolled and followed for 1 year. We had 29 success. One patient actually was treated after 4 US RFA session and was considered a failure because by definition there were no more than 3 US RFA session, and we had 4 patients with adverse events, 2 patients with very mild acute pancreatitis that did not require a prolongation of the hospital stay. One patient who developed a hematoma of the gastric wall, and one patient who developed PD stenosis. And this was strange because in our inclusion criteria, there was a distance at least 2 millimeters from the PD. In fact, and this was based on the work of the French group, where a patient from Napoleon that was less than 1 millimeter from the lesion was less than 1 millimeter from the duct had developed ductal stenosis that was treated endoscopically. So in our patients, the lesion was 4 millimeter away from the duct, but she or he, I don't remember, developed a ductal stenosis that anyway was treated endoscopically. So if you look at this complication and the complication of surgery, I don't think you can really even compare them. So there is really evident that that this is the way that should go, because the patient becomes euglycemic the day after, so is treated the day after when it responds right away, and after treatment the relapse rate is really infrequent. So in my mind, this is the treatment to go. There's no question about comparing with surgery. For non-functional is a little bit different, because in non-functional you need to ablate all the tissue, even though you will never have a proof that you ablate all the tissue. But also this is a paradigm, is not proven. So I think when we will have many patients treated with follow-up, we will be able to see and to take and to give answer to many questions that are still open. So for now, non-functional are still limited to certain patients, while I think for functional the treatment with RFA should be first line. What do you think?
And in our I totally agree with you, and this is our policy now, because not because of only the complications, but the efficacy is there is 50% failure of alcohol. Yes. And half of the patient went to major surgery, and half of the patient went to radiofrequency ablation. So our policy now, I will not do alcohol injection anymore, radiofrequency ablation only after discussing the issue with the patient, of course.
And in Egypt, which is the most of the patients like this are treated with endoscopy, or most of the patients are still treated by surgery, by surgeons?
Most of the patient now by surgery, because it is the usual practice for tens and hundreds of years. But now with multidisciplinary team,
so we are in the mummy, no?
I did only 2 cases 4 years ago, and in the last year more than 7 to 10 cases.
But
this means that there is progressive.
There is a trend. There is a trend for the patient to start getting. The patient after they go to surgeons to discuss, then they go on internet. So I've seen most of the patients I've seen were patients who had been to visit a surgeon and then went on internet and found me and come to me without the surgeon recommended to tell them. So it's really by internet, and I think this is not really the way it should be. And do you have any other experience in terms of RFA for other kind of lesions?
No, it can be applied to many.
Like, did you have any pancreatic masses, pancreatic metastasis, for example, or adenocarcinoma?
No. My experience is 12 cases, all were pancreatic. But of course, if there are suitable cases for radiofrequency, like solitary metastasis in even cancer rectum or cancer colon, or even pancreatic, I will offer radiofrequency ablation. But till now, I didn't do it. In our practice in Egypt, the surgical segmentectomy at the time of radical surgery for the primary tumor. But I think this is the most second important. And sometimes I did it intraoperative sonography guided. intraoperative
Okay.
sonography guided by the usual radiofrequency ablation, percutaneous one, but intraoperative.
Okay.
But if it is the patient is having cerebral metastasis, why not doing it EUS guided?
Yeah, because I have a pretty extensive experience with metastasis.
Yeah,
so solitary metastasis by so lung, colon, ovarian, renal. Even though renal, they don't respond very well. I don't know why. And then we have also experience in hepatocellular carcinoma in the left lobe. We have done a pretty 7-8 cases. So I think radiofrequency ablation can also be utilized for lesions in patients, for example, who are at high surgical risk. For example, I've done a lady with 8 years old with the colon cancer 20 years before, who developed a recurrence after 20 years. So she had a lesion, paragastric, 3.5 centimeter. And she had many surgeries in her life, ovary, gynecological. So she didn't want to go any more surgery. And so I did two sessions of pretty extensive ablation, and she had the PET scan, the control PET scan 2 weeks ago, and was clear. It was totally negative. So I think that radiofrequency ablation will find is road also for conditions, especially in patients at high surgical risk. So where the risk of surgery is high, and then you can do RFA instead.
Yes. You can save the patient major surgery, of course.
Yeah, at the end, it's not a highly invasive procedure. It's pretty, it's not difficult to be performed. So you just need to learn how to use the needle a little bit, what the margins needs to be taken into account, the wall. But these are really very easy to learn things that can be really learned in 1 to 2 procedures, and then you can really do by yourself. So yes. Thank you very much for this kind of procedure and explanation, and I'm very happy we met each other, and I will be in Cairo at the end of November, and I will email where I am, and maybe we can get in touch.
Yes.
Okay.